Good afternoon. As I said just a moment ago, my name is Dawn Boender. I am an OBGYN who also was trained in practices within reproductive behavioral health. And today I'm going to be talking about an update on screening and treatment of anxiety and depression in pregnancy and postpartum. The learning objectives by the end, you'll be able to list screening tools that are available, list diagnostic criteria for the perinatal mood and anxiety disorders, specifically anxiety and depression, and then describe first line treatment strategies for perinatal anxiety and depression. I just wanted to touch very briefly on the baby blues. So this is not the same thing as postpartum anxiety and depression. This is very common, affects 60 to 80% of mothers. It can last between 2 days and 2 weeks, peaks around day 3 to 5. Um, Mothers will often note being tearful, mood lability, exhaustion, but their self-esteem will remain unchanged. This is due to big hormone fluctuations, acute sleep deprivation. Again, this is not postpartum depression, but this is something that is very typical for women postpartum. What we will be focusing on are the perinatal mood and anxiety disorders. So breaking that down, perinatal means from conception until baby is a year old. Mood, depression, bipolar, psychosis, anxiety would be generalized anxiety, panic, OCD, PTSD, and disorders, which are indicates it affects daily functioning. These are called many different things, but for the that have similar names. So postpartum depression falls within this. Sometimes individuals will use that as a blanket term for everything, even though it's more specific. But for my talk, I will refer to them as the PMADs. They do affect 14 to 20% of pregnancies. It's listed between 1 in 7 to 1 in 5. The American College of Obstetrics and Gynecologists listed as 1 in 5 because they're also including the mood anxiety disorders that women may have had entering into pregnancy. So sometimes the numbers vary based upon if we're including all of the mood anxiety disorders or just some, or if it's new or if it's existing. But in general, 20% of women will experience some form of a PMAD. And so a big takeaway from that is we do need to be screening our patients and we need to be treating them if this is something that is affecting them. Looking at a study from back in 2013 when they Wisner et al. Had followed 10,000 women and they looked at the incidence, how often PMADs were happening and when they started. And 33, and I think this is important to note because when we talk about mood and anxiety disorders surrounding pregnancy, it's not just that it happens right after delivery. So about 27% had pre-existing that then worsened or persisted through the pregnancy. 33% or a third, it started during their pregnancy, and 40% it started after pregnancy. In that study of the PMADs, if they were pregnant or present, 68%, so 2/3, a little over 2/3 had unipolar depression, so major depressive disorder, postpartum depression. 66% who had depressive disorder also had an anxiety disorder. 22% had bipolar disorder. And of the women who were in the study who endorsed having a mood or anxiety disorder, 19% of them had thoughts of self-harm. And so that's really important because that's a really high number of our postpartum patients or pregnant postpartum women. So as far as screening, I'm not going to go too much into this, but most of the major organizations for providers do recommend screening pregnant women during pregnancy, postpartum. And from the standpoint of screening, there are a lot of different screening instruments that can be used. And so what I would really encourage or recommend is if you are doing screening that you have a system in place within where you work, your organization, of these are the screening tools that we use. But this just lists some of the screening instruments that have been validated. So depression, EDPS, PHQ-9, anxiety, the GAD-7, EDPS or EPDS. You can look at some of the components of that. There's screening for bipolar disorder. So this table just gives us an idea of some of the different screening options. When you're looking, this is just as a reminder that in that previous study, it had showed as well that some women who are diagnosed with depression or anxiety in pregnancy actually have bipolar disorder. And so it's really important to include screening for bipolar disorder as well, if you're getting, especially if you get a positive screen on the depression scale. And this is just one other option because sometimes it's for providers who are not as used to screening for bipolar disorder, or that's not part of their normal workflow that they do. This is just another option for screen, or another example of a screen for bipolar disorder. So how are the PMADs diagnosed? Well, we diagnose them using the same criteria that we would if you are outside of pregnancy. And so we would screen them with the most common diagnoses that we do see is major unilateral depression or major depressive disorder, generalized anxiety disorder, panic disorder, obsessive compulsive disorder, PTSD, bipolar disorder, which about 22% who screen positive for postpartum depression with further testing did have bipolar disorder. So that's why it's important to include that in that. And then psychosis is another diagnosis that we definitely want to be aware of that happens postpartum as well. And so we use the DSM-5 for our diagnosis. Within the DSM-5, there are what we call specifiers. So if an individual meets criteria for a DSM diagnosis, there's only specifiers with depression and bipolar that has with peripartum onset. And so we know a lot of different mood and anxiety disorders can be associated or have that onset during pregnancy, postpartum. As of right now, the DSM-5 only has the specifier listed for depression and bipolar, even though, as I said, anxiety can initiate, OCD can initiate in pregnancy, postpartum, things like that. And then I won't go into this. This is just showing or reminding that there is very set criteria for individuals. Oh, I have a message that somebody can't hear. If that's a generalized statement that others can't hear me, please put another message so that I know.
Keep going. You're fine.
Okay, thank you.
Thank you.
So with this is just a reminder that the DSM does have set criteria for major depressive disorder, anxiety disorder, the different disorders. You can go through the next ones pretty quickly because I'm not going to break down each one individually. It's just so that individuals and providers are aware that there is, and you can go through the next one, is very set criteria for each of the different mood and anxiety disorders that we are diagnosing. One of the things that is really important to be aware of is maternal suicide is one of the reasons for maternal mortality. So mortality related to pregnancy and postpartum. And a lot of times it actually happens a lot later than what individuals realize. And so you can see that during pregnancy and within the first 42 days postpartum, that makes up less than 20% of maternal suicides, where most are occurring later in the postpartum time period, with a peak incident between 6 and 9 months postpartum. When we look at South Carolina's data, and this is from their maternal morbidity and mortality review, so when we're looking at South Carolina's data, the leading causes of pregnancy-related deaths, mental health condition, substance use disorder was 15%. And just like the previous timing that we see with suicide as well, you can see that it's later that we tend to see the pregnancy-related deaths as well. So between that 43 and 1 year is when the biggest proportion is. And just very briefly about that too, you don't have to go back in the slide, but very briefly, any of the mental health conditions, substance use disorders, like those are considered, when we list them, are considered preventable deaths. And so it is really very important that we be screening and then getting our patients into treatment who are having difficulties with their mental health in pregnancy and postpartum. So as far as treatment updates, when we talk about treatment, it's not necessarily just medication. I do like from Postpartum Support International, they have a saying where they say, "You are not alone. You are not to blame. You are not to blame. With help, you will be well." Because a lot of times it can feel very isolating to women when they have mood and anxiety disorders in pregnancy and postpartum, because everybody's telling them that they should be happy. But just helping them to know you're not alone. With help, you will be well. And there's a lot of steps to helping with mental health. And so this is from one of the fact sheets from Maternal Mental Health Alliance that I think is good, that just kind of goes through some of the different steps, depending upon if your symptoms are mild, moderate, severe. But if they're mild, we know that sleep is really important. So doing some self-care things is sometimes the first step for those more mild symptoms. So making sure they're getting adequate sleep, adequate nutrition, getting the time off that they need, adding in the social support, and having friends, families, doulas, the home visiting programs and support groups that I know on these talks we have individuals that are those as well. Those are all very important. We know that therapy and counseling is really important as well. And then medication is what I spend a lot of my time with, but that is definitely a component. But it just depends upon, for each individual, their level of symptoms that they're having, where we would recommend starting. But I think it's good to remember that there's a lot of different components that we can work towards improving for our patients. And so this goes through as well, just some steps for wellness, sleep. Even if we can improve for sleep to 4 to 5 hours, I mean, obviously that's still much less than ideal, but for some postpartum moms, they're not even getting that. So being very mindful of, okay, what are things potentially we can put in place to help you with your sleep? Nutrition, I like to tell my patients, because a lot of times they will just feel too overwhelmed to make themselves snacks or make themselves meals, or their mood is inhibiting that, or their baby's colic is inhibiting that. So we talk about, can you have a feeding station where others can help you make very easy, grabbable, pre-made snacks, so that when you are feeding baby, you can remember to grab a snack yourself, but that it's already there, it's already ready. Doing the exercise, making sure that the mom is getting time off alone, that scheduled time where they can relax, where it's not necessarily the only time they get is in the shower while the baby is still crying on the outside of the curtain and they're trying to get some of that time in. So being mindful of the self-cares, and then social support as well. One of the things that I really like, and I'll have that's I had heard previously, and I'll tell this to my patients as well, is a lot of people do want to help when you have a baby, but sometimes that means that they actually want to just come and hold your baby. And so if you're feeling overwhelmed, make a list of things you need done. So when your friends and family come and they say, "Hey, how can we help?" you can just point to the list and say, those are things, very tangible things that can help take some of these things off of my plate. But sometimes they just need to feel empowered to be able to do that. So support groups we know are really helpful as well. And at the end, I'll go through some of the support groups that we have that are free support groups that are great for patients. And so I'll share some of that with you. But the key takeaway is new parents need to know that they're loved, they're valued, that they have support. And so finding some of that just as some of the basics, especially when it's more mild symptoms that they're feeling. As far as therapy, there's lots of different types of therapy: cognitive behavioral therapy, interpersonal therapy, mindfulness. So there's a lot of different types of therapy, but we know that therapy is beneficial and we know that it's helpful. And studies have shown that. And so that's another thing to really encourage our patients who have perinatal mood anxiety disorders to participate in therapy if they're able. We also know that when we get into medications do have side effects and do have risks. Therapy, the risks are very minimal, but the benefits are very great from that standpoint. So remembering to encourage that in our patients. And then as far as medication, when we do approach medication, the goal is to have the lowest effective dose, but the key there is effective. We want to avoid under-treating as well. So we don't want to start somebody on a medication, but also not treat their symptoms, because now they have a medication and they still have their mood and anxiety symptoms that are present. So we want to use the lowest effective dose, but we want to avoid under-treating, avoid polypharmacy if we can. So if medications are working but not as much, go up on the doses if we need to. We're also, our goal is to avoid multiple medication trials. So by this, I mean, if we are in pregnancy itself, so if it presents in pregnancy and a woman says, I have had this medication be beneficial before, then that probably is the best medication to start them on, unless there's a contraindication or a reason not to in pregnancy, instead of starting something completely new that we may have to then change, especially if they've had multiple medication trials in the past. So if we know what has worked for them, using that if we're able to. It's also good to remember that the physiologic changes that happen specifically in pregnancy, the blood volume increases, the kidneys are processing things faster. And so and filtering things faster. So as you're seeing these physiological changes, it might require increasing the doses of the medication. So if you have a patient with a pre-existing mood or anxiety disorder and they've done really well, and then in the third trimester their mood is worsening, they likely just need a higher dose, because even though they're taking the same amount, it may not be the same levels that they're getting as a result of that. It also is not recommended for somebody who's on medications during pregnancy to try to decrease the medication before delivery in preparation for delivery. So in the past, that's something we had to discuss, but we don't have any data showing that's helpful. And it can be the opposite, where it's harmful because it's risking destabilizing their mood right before they have a big hormone shift and potentially have worsening mood symptoms as a result. So don't try to decrease that. And what I tell my patients is my goal, especially if I'm starting them on a newer medication for new symptoms during pregnancy, postpartum, is I want their mood to be well controlled for about 6 to 12 months before I start tapering it back. I aim closer to 12 months if it's anxiety symptoms they're having, 6 months if it's more the depressive. But even when we start, as a lot of individuals, if they've never had mood or anxiety symptoms, are hesitant or have a lot of questions about the medications, that's what we talk about, is to get their mood in remission. And then at that 6 to 12 month mark, we'll talk about tapering the medication back. And then just some basics about breastfeeding is our goal with breastfeeding overall is for medications is the relative infant dose under 10%. That's not standard across the board, doesn't work for every medication, but that relative infant dose refers to the amount of medication that we see in the breast milk in comparison to what mom is taking. And so most of the medications that we use do have that low relative infant dose, which is a good thing. Selective serotonin reuptake inhibitors, or the SSRIs, you can go to the next slide, is one of the first lines that we use for medications. As far as risk that we talk to with patients, from the data, we don't see increased risk for miscarriage. We don't see increased risk for congenital anomalies. Paxil, that is the one that's different. There was some concern for cardiac malformations. Newer data is less concerning. But if a patient was already on that, I would discuss that with them. But otherwise, a lot of patients will stop if they are on pre-existing, if they do have pre-existing mood or anxiety disorders and are on an SSRI, will stop it right when they find out they're pregnant. We don't recommend that. We don't expect it to cause any concerns early on. And we do know that there's a 2/3 or 66% chance of relapse of their mood disorder if they stop that. The rate of earlier labor, we don't see as different between individuals with mood and anxiety disorders, whether they're treated or not. Low birth weight. So initially, some of the older studies showed that the SSRIs had concern for preterm labor. The babies had low birth weight or would be a little bit smaller. But they were comparing women who were on the SSRIs to women who did not have a mood or anxiety disorder at baseline. So it wasn't a good comparison, because we actually know that one of the risks of untreated mood and anxiety disorders in pregnancy is that baby can be a little smaller or born a little bit early. So when I talk to women about SSRIs, I tell them it's important to compare women who with the same conditions who are treated versus untreated. And so we don't expect there to be clinical significance in the changes. If there is lower birth weight, it's typically just by about 3 ounces, which is not clinically significant. One of the things we do know about the SSRIs is that they can have neonatal adaptation or discontinuation syndrome, which is not the same as the NAS we talk about with opioids. So it's not the withdrawal that we see with opioid discontinuation or opioid use, but this is a transient condition. Neonatal adaptation syndrome is transient. It happens in, the estimate is 10 to 30% of women who are on SSRIs during pregnancy. Baby has a slower transition. They're a little more irritable, restless, might have a little bit of difficulty with feeding. Typically, though, they just need supportive cares, more skin to skin, things like that. About 1 in 300 will need some higher level nursery to help with that. But like I said, it is transient. We expect it to go away on its own, usually within a few days, can last up to 2 weeks. Whereas individuals who have untreated mood and anxiety disorders, babies have a higher risk for colic. Moms have a higher risk for worsening mood after delivery. It can have some attachment issues, things like that. So from the standpoint of risk to baby, for my moms who have moderate to severe symptoms, we do talk about the risk for the adaptation syndrome. We feel is lower than the risk for their untreated mood and anxiety disorder that we see with that. One of the things you'll find when you Google it too is the risk for persistent pulmonary hypertension, which is a serious thing, but there's an association, but it's only about 1 in 1,000, so very low. And a lot of things have associations with persistent pulmonary hypertension. And so I go through some of that with patients, but that's not something that we would expect to see. And then, like I said, we don't recommend down titration in the 3rd trimester or immediately postpartum. Some of the other medications, lamictal and lithium, which are not SSRIs, we would have different conversations with, but the SSRIs, we would not recommend just automatically going down right around the time of delivery if they did needed to go up in pregnancy. And then with breastfeeding, they have low relative infant doses. We tell all moms, just like anything that they're taking, you would want to watch for any side effects with baby. And I tell mom that's the same if you're eating chocolate or broccoli or really anything. You want to watch how your baby responds, but we don't expect there to be significant responses or side effects with breastfeeding and SSRIs. And then SNRIs are very similar as well. They do have to SSRIs, but the data does show maybe a slight increased risk for preeclampsia and a slight increased risk for miscarriage, but that was very low quality data in those studies. So the big takeaway is some psychiatric medications we do know have some side effects, but the bottom line is don't stop them without a plan. And also, studies have shown too that without an intervention in place within a practice, if you are doing screening and don't have some kind of intervention set up, less than a fourth of women will receive treatment. So it's important to have an actual plan for your patients who either have a pre-existing history of mood anxiety disorder or who screen positive in your practice. And then this is ACOG has a really nice, they have a practice guideline that came out in June of 2023. I know you can't see this. This is just to show you they have really good algorithms for if in your practice somebody does screen positive and you're waiting or you're wondering how to first start them on medications or you're waiting for them to get in, things like that. So this is a good resource. So the site is just for resource. Zuranolone, I'm going to touch on very briefly. This is the new FDA-approved medication that came out in 2023. It is the only FDA-approved medication specifically for postpartum depression. It acts on the GABA receptor. Individuals who qualify, they need to meet criteria for depression. It needed to start within the 3rd trimester or within the first 4 weeks postpartum. So if you have somebody who has baseline depression that hasn't changed, or their symptoms start at 6 months postpartum, things like that, they would not meet the criteria for Zuranolone. Also, it would be for moderate to severe. So if they had very mild symptoms, I would not recommend this at that point, but this is a newer medication that's good to be aware of. And there's very clear patient instructions. We've done a presentation just on this as well. But this is something that for some of our patients has done a very nice job. And it's, like I said, the only medication that has specifically been FDA approved for postpartum depression. And it is a sedating. And so there are warnings that come, black box warnings, that they can't do hazardous activities. It's for 12 hours after each dose, because this is taken for 2 weeks, and can cause CNS depression as well. And you won't want to use it if you were pregnant.
So, Dr. Boender, I know
Yep.
that you have a few more slides. I think
Yep. This is
let's take a
actually,
break. Let's just
oh, I
take a
was going to
break
say,
right now. Okay.
okay.
For
The rest of
questions.
my slides are actually the resource slides that I was telling you, that are just
Okay.
for them to look through if they're looking for like where to find support groups, things like that.
Okay. Well, I can revisit those at 1
Okay.
o'clock. And
Okay, perfect.
let me go ahead and stop recording. 1 second, everyone, please.